Thank you.
Good evening, everyone. We have two very talented people, Manoj Makharia, and to chair the session, Dr. Bhimania, our teacher, S.K. Bhimania sir, Dr. A.N. Rai sir from Gaya, Dr. R.K. Adwal sir, and Dr. Kausal Vikram, sorry. So we have two very talented people speaking back to back. Dr. Manoj Makharia, who is speaking on AF's latest ESC guidelines and current perspective of atrial fibrillation ablation by our loving Dr. Mithilish from Indianapolis. Over to you, Dr. Manoj.
Yes, let me introduce first Dr. Makharia, son of the soil from Bihar. He is working in NHS Trust UK for last so many years. And he is a learned speaker going to speak on a very important topic of atrial fibrillation, the latest ESC guideline. As we know, atrial fibrillation usually not life-threatening, but at times it becomes a serious medical condition which requires medical management. As because blood clots develop in the different chambers of the heart, may lead to stroke and other serious consequences. Therefore, I think the early detection and timely intervention to prevent progression of disease and its complication is of utmost importance. So may I request Dr. Makharia just to say, guide us on the latest ESC guidelines of atrial fibrillation. Over to Dr. Makharia, please.
Thank you for the kind introduction, and thank you, CARDICON 2021, to invite me to speak to this august audience. I hope my slides are visible to you. So I'm going to speak to you, tell you about the latest ESC guidelines. So as you know, AF is the most prevalent arrhythmia worldwide. It's more common in Northern America and European subcontinent. But in India also, approximately between 600 to 700 people per 100,000 are suffering from atrial fibrillation. So it's a very important disease that is usually ignored, especially in India. So ESC has come up with a very simplified way of managing atrial fibrillation. So what they said is CC to ABC. What is CC is the confirmed atrial fibrillation, characterize the atrial fibrillation, and then manage the atrial fibrillation by ABC pathway. And ABC pathway is anticoagulation, better symptom control, and management of cardiovascular risk factor that is often ignored in patients with atrial fibrillation. So quickly going to the guidelines. So how do we confirm atrial fibrillation? So guideline says that we should say patient has atrial fibrillation only if we have a 12-lead ECG confirming atrial fibrillation. If you are using a single lead ECG, then you should have at more than 30-second tracing of ECG to confirm that patient has atrial fibrillation. Nowadays, we are implanting so many implantable devices like ICD, pacemakers, and nowadays implantable loop recorder. So sometimes we found that patient has got atrial high rate episodes. So these atrial high rates episodes is very difficult to say whether they are atrial fibrillation or not. And ESC has come up with a new diagnosis, new definition of atrial fibrillation called subclinical atrial fibrillation. So if you found patient has got atrial high rate on device, then you do an ECG. And if ECG confirm that patient has atrial fibrillation, then you treat that patient as a clinical atrial fibrillation. Otherwise, the patient will be called as subclinical atrial fibrillation. So screening here in UK, we always do opportunistic screening. The patient comes to a clinic and is more than 65 or hypertensive or had obstructive sleep apnea syndrome. We check the pulse, and if pulse is irregular, we confirm it by ECG. A systemic ECG screening is recommended in people who have aged more than 75 or had a high risk of stroke. So there is always risk and benefit of screening any disease. So risk is that you're gonna tell the patient that you've got abnormality and it will make him anxious. ECG can be misinterpreted and can be misdiagnosed, overdiagnosed, overtreated. But benefit of screening of atrial fibrillation, if you diagnose it, to prevention of a stroke. That's a very important catastrophic event if it happens. So how do we do the screening of AF? So it can be done through the electronic blood pressure monitoring. You can feel the pulse. Nowadays, all the smartphones have got apps where you can look at the ECGs. You can use 24-hour heart holter. You can do 7-day holter. You can use patch. You can implant implantable loop recorder if you have high suspicion of atrial fibrillation. So coming to classification, traditionally atrial fibrillation has been classified as paroxysmal, persistent, long-standing, or permanent atrial fibrillation. But there's a new category they have said we should say is the first diagnosed atrial fibrillation, when there's no previous diagnosis and patient comes to you with the first new diagnosis of atrial fibrillation. ESC says that we should not use the terms like lone atrial fibrillation or valvular or non-valvular atrial fibrillation or chronic atrial fibrillation. So the next thing is characterization of atrial fibrillation. So whenever you are looking for patient with atrial fibrillation, you should remember 4S AF scheme that has ESC introduced. What are the 4 S's? The 4 S's are stroke risk assessment, symptom severity assessment, severity of AF burden, and substrate severity in the form of whether they are by the imaging. So we know that patient has got risk factors for stroke, and they have you factored in all these common risk factors and created a score called Chad-Vass score. Initially, we used Chad's score, but now it's a Chad-Vass score. I would like to just stress one point in this slide is that in Asian subcontinent, the data shows that the stroke risk starts between the age of 50 and 55. So what ESC is saying that we should use modified Chad-Vass score for risk assessment in patient in Asian subcontinent. We all know that AF can be asymptomatic or can be symptomatic, present as palpitation, breathlessness, fatigue, or can present as a catastrophic event like syncope or acute heart failure, pulmonary edema. AF can cause lots of morbidity and mortality. It increases the risk of death, stroke, heart failure. It also causes cognitive decline, and it impairs quality of life and increase hospitalization. We should always quantify the symptom of the patient by EHRA symptom scale, as we do for NYHA class or CCSA class for angina. What is recommended is that in patient with atrial fibrillation, we should evaluate AF symptom and quantify the patient's symptom status. And we should also evaluate the symptoms after and before and after cardioversion of persistent atrial fibrillation, so that we can make some conscious decision whether we should be aiming for rate control or rhythm control strategy. All patients of atrial fibrillation should have a thoracic echocardiogram. Some patients will need transesophageal, and some of them will need cardiac CT scan and cardiac MRI scan to identify any reversible cause or what is the structural heart disease underlying. Risk factors for atrial fibrillation are multiple. Some of them are non-modifiable, like aging, ethnicity, male sex, and genetic. But other risk factors we can look into and treat them and reduce the recurrence of atrial fibrillation. Coming to the management of atrial fibrillation, as I said, it's an integrated ABC pathway. And coming to anticoagulation part first, all patients should be risk assessed for risk of stroke by using Chad-Vass score. If the patient has mechanical heart valve or has moderate to severe aortic mitral stenosis, then this patient should be referred for vitamin K antagonist treatment, anticoagulation like warfarin. But if the patient doesn't have a prosthetic mechanical valve or doesn't have a moderate or severe aortic stenosis, mitral stenosis, then we should risk stratify these patients according to Chad-Vass score. If the risk is low, like Chad-Vass score is 0 in male or 1 in female, then they don't need antithrombotic treatment. But if the risk of Chadwick score is 1 in male or 2 in female, then this patient should be considered for oral anticoagulation. And if the risk is high in the male, it is more than 2, or in female, it's more than 3, then we should be recommended anticoagulation treatment. The other thing we should do is that we should look into modifiable bleeding risk factors and calculate bleeding risk factor by using Hasblad score. So what ESC says that for stroke prevention in AF who are eligible for anticoagulation therapy, NOACs are recommended in preference to vitamin K antagonist treatment, except in the mechanical valve and mitral stenosis. For stroke risk assessment, risk factor-based approach is recommended in the form of Chadwick score, and patient who had a high risk, Chadwick risk should be recommended for oral anticoagulation treatment. OSC should be considered for stroke prevention in AF if the Chadwick score is 1 in male and 2 in females. For bleeding risk assessment, we should use Hasblad score and make sure that any modifiable risk factors are addressed before we consider that this patient is at high risk and we could not prescribe anticoagulation. The other things we should be considering is that we should be periodically evaluating this patient for risk of stroke and bleeding. In patients with AF initially at low risk of stroke, they should be re-evaluated at 4 to 6 months to assess whether they have any change in their risk of stroke. If the patient is on vitamin K antagonist like warfarin, then we should target for INR between 2 and 3 and aim to time in therapeutic range more than 70%. In a patient with warfarin, if the low time in therapeutic range, then this should be switched to the newer oral anticoagulation treatment. And if we want to continue warfarin, then every effort should be made to improve the time in therapeutic range. Antiplatelet alone is not recommended, is contraindicated, it should not be used in patients with atrial fibrillation. Estimated bleeding risk in the absence of absolute contraindication of NOAC should not itself preclude patient from having anticoagulation treatment. Some people may have absolute contraindication of oral anticoagulation treatment. In those patients, occlusion or exclusion of left atrial appendage, either by device closure or surgical, should be considered. The one important thing I would like to stress here is that we use these NOACs every day, but I have seen lots of people are given reduced dose. But actually, whenever we are prescribing reduced dose of NOAC, we should make sure that dose reduction criteria is met. Otherwise, there is no point of giving NOAC in patient in subtherapeutic dose. So better symptom control. How do we control the symptom better? So what ESC recommend that we should aim for lenient rate control. That means we can accept heart rate of less than 110 beats per minute. If the patient remains symptomatic after rate control then we should consider more aggressive rate control and aim for heart rate of less than 80. But if the LV systolic function is deteriorating with the lenient rate control, then also we should consider for tighter rate control. And how we can do that, either we can ask for rhythm control strategy, or we can refer them for AV node ablation, accepting that they will need a long-term pacemaker implantation. So what are the drugs we use for rate control? So traditionally, we have been using beta blocker, non-dihydropyridine, calcium channel blocker, digoxin, and amiodarone in some cases. So what ESC recommend that beta blockers, diltiazem, verapamil are recommended as first drug choice in patient who has got LV ejection fraction of more than 40%. If the patient has got LV systolic dysfunction, then the beta blocker and digoxin should be used in this patient. A combination therapy comprising 2 or 3 rate limiting medication is considered and recommended for better rate control. A resting heart rate of 110, less than 110 should be considered as the initial heart rate for rate control therapy. AV node ablation should be considered to control heart rate when patient is unresponsive to multiple rate control medication. And and should be considered for further LA ablation, accepting this patient will need a pacemaker. So coming to the rhythm control strategy. So when do you consider rhythm control? So rhythm control is required in patients who are symptomatic despite having a good rate control. If they are still symptomatic, then, and if you are considering for rhythm control, then you should be looking at the factors that would favor long-term rhythm control, like young age, a shorter duration of AF onset, tachycardia, induced cardiomyopathy, LA size, whether patient has got multiple comorbidities or not, and whether patient has acute illness like pneumonia or acute sepsis that may have triggered the atrial fibrillation. And for rhythm control, you can use either antiarrhythmic medication or ablation or cardioversion. So what is recommended is rhythm control therapy is recommended for symptom and quality of life improvement in symptomatic patient with atrial fibrillation. So coming to the mode of rhythm control. So cardioversion is one of the important things that we use often to control the atrial fibrillation rhythm. So before considering cardioversion, you must check the oral anticoagulation status. If the patient, before that you should look at the hemodynamic stability. If the patient has any hemodynamic instability, the patient goes for emergency cardioversion, and you assess the oral anticoagulation therapy afterwards and treat it as a Chad-Vasey score dependent. But if the patient is hemodynamically stable, then check the oral anticoagulation status. If they are anticoagulated, they can directly go for emergency cardioversion. But if they are not anticoagulated, then you have to check the duration of atrial fibrillation. If the duration of atrial fibrillation is less than 48 hours, then you can choose to do an early cardioversion, either TOE guided, and if you are certain that AF onset is less than 24 hours, then you can directly go for cardioversion either electrically or pharmacologically. Elective cardioversion is recommended if the onset is more than 48 hours of onset, and you must anticoagulate them immediately as soon as you diagnose the atrial fibrillation. So these are the recommendations for cardioversion as we discussed. The important thing is that pre-treatment with amiodarone flecainide is recommended to facilitate the successful cardioversion. And in some selected patients, you can use fill-in-pocket strategy to prevent any further recurrence of AF recurrence. In patients with sick sinus syndrome and AV node conduction disease, pharmacological cardioversion is not recommended. So we must use the look at the stroke management in this patient with cardioversion, and this patient should have at least 3 weeks of oral anticoagulation before cardioversion and at least 4 weeks after cardioversion, and then you decide long-term cardioversion, long-term anticoagulation on the basis of Chad-Vasey score. So what it says that TOE can be used to guide your cardioversion. If you're keen on doing cardioversion in the patient who has got shorter onset of atrial fibrillation, then you must do a TOE and rule out any LA clot. In patient who has a low Chad-Vasey score or 0 Chad-Vasey score and who AF onset is less than 24 hours, in these patients, post-cardioversion, you may omit the 4-week anticoagulation. The other important thing is that you must consider doing the follow-up of these patients in atrial fibrillation after cardioversion to assess that they are maintaining their sinus rhythm after cardioversion and whether their symptoms have improved with rhythm control or not. The other way of rhythm control is catheter ablation. It is a patient choice. You must discuss the pros and cons of ablation because it's an invasive procedure. And if the patient want to have the catheter ablation, then you should refer them to electrophysiologist. Antiarrhythmic drug sometimes does not help in maintaining sinus rhythm. Then you also can refer them for catheter ablation. I think the next talk is on catheter ablation. So I'm not going to tell much about that here. Long-term rhythm control strategy could be either long-term antiarrhythmic medication in the form of dronedrone, flecainide, propafenone, or sotalol or amiodarone, or it could be, or you can use catheter ablation for long-term rhythm control strategy. So flecainide and propafenone is a recommended long-term rhythm control strategy. As I said, dronadone is not used in patients with LV systolic dysfunction. Amiodarone should be used in patients with heart failure and in patients who are prescribed sotalol for long-term antiarrhythmic. You should check the QT interval on a regular basis and serum potassium. And antiarrhythmic drugs are not recommended in patients with permanent atrial fibrillation. So comorbidities is another thing that we need to look at. What ESC says that identification and management of risk factor and concomitant disease is recommended as an integral part of treatment of AF patient. We normally ignore all these risk factors. That's very important. Modification of unhealthy lifestyle is also a target. Opportunity screening is important. Blood pressure control is also required. In obese patients, weight reduction is very important. Advice and management to avoid excess alcohol is also important thing. Physical activity is another thing. So excessive endurance exercise can promote atrial fibrillation. So moderate exercise is recommended. And optimal management of obstructive sleep apnea syndrome is also indicated. So as I said, counseling professional athlete that long-lasting intense sports participation may promote atrial fibrillation, while moderate activity is recommended.
Dr. Manoj, try to conclude, please.
Yes, so in conclusion, I can say that CC to ABC is the new norm for AF management, and integrated pathway using ABC pathway using anticoagulation, better symptom control, and comorbidity management is essential in management of atrial fibrillation. Thank you.
Thank you, Dr.
Thank you. Oh, so
Very nice talk, well explained, and quite in detail. If there are any questions from the audience, after the second talk.
After the ending of the another talk.
Yeah, thank you.
I invite Dr. Mithilish Das, next speaker, who is son of soil, and at some point we have lived together in Betia, if he remembers. And then he moved out to Ranchi and then finally to US, did fellowship in ET and all, and he's a big man now, doing a lot of interventions in electrophysiology. So Dr. Mithilish Das, please.
Thank you, Dr. Sinha. Thanks for inviting. Really, this is my privilege to present about AF ablation. And let me start sharing my slides. Can you see my slides?
Yes. Yes. In your side.
So no, I will just go around the indications and limitations of AF ablation, and will answer questions at the end. So I'll start with a case. This patient presented a few years ago to us. He's a 66-year-old man with history of hypertension, diabetes, and recent episodes of palpitations, weakness, and lightheadedness. When we saw him, he was obese, he was short of breath, O2 sat was like 90%. He was desaturating intermittently. He had signs of heart failure. He had blood pressure was low and pulse were irregular. You can see the ECG. So the question was at that time, what's the immediate risk? What is short-term risk and what's the long-term risk for this new onset AFib? And how you manage immediate management, short-term management, and long-term management, and what we discussed with the patient. So this patient was not anticoagulated from before. So we did a T, there was no clot, we cardioverted to sinus rhythm. And then we found him EF of around 35%, TSH was normal, X-ray showed CHF. Later on, he went to stress test and there was no coronary artery disease. He was treated with Lasix, ACE inhibitors, low dose beta blocker, and initiated on apixaban. So the question he asked us, what's my prognosis? What's my lifelong medications? And we talked about maybe heart failure can happen in few patients, like 20 to 30% patients, and his EF is 33%. So is it reversible? And then we talked about risk of stroke. So most important thing which we emphasize in patient management of AFib is patient education. And we talked about the spectrum of AF, clinical spectrum. We all know paroxysmal, persistent, or permanent. Patient could be asymptomatic, may present with rapid ventricular rates. They can have tachybrady syndrome, which is difficult to treat. Up to 20 to 30% patients will have CHF and cardiomyopathy and risk of thromboembolism. And it is associated with higher mortality, poor quality of life, recurrent hospitalization, and there are some data that it may cause dementia. So he was started on sotalol and heart failure therapy. And after 3 months, he was asymptomatic. He was doing well. He reduced weight in 3 to 6 months. He used a sleep mask, and his blood pressure, diabetes well controlled. But 1.5 years later, the AF recurred. He was cardioverted again and started on dofetilide. He was on good heart failure medications, but the EF of 45%. He was doing well for a year, and then he presented with heart failure again, with symptoms for 2 weeks, with the heart rates in 140s. Heart failure signs were there. We cardioverted him again, but the EF was around 28% now. So now he has tachycardia-induced cardiomyopathy, and we had managed his diabetes, hypertension, sleep apnea, and obesity. Now our treatment options are amiodarone, AV node ablation, and catheter or cryoablation. So modifiable risk factors and irreversible and non-reversible causes we discussed with the patient, and we worry about all this non-reversible risk factors, and none of them was there with the patient. So why this is so important to intervene early? Because patients with paroxysmal, they change in few months to persistent and then long-standing persistent. And if you do that, and if you don't intervene early, the results are bad. So if you intervene early, there are better results, and we prevent complications. So we tend to work in paroxysmal phase and early persistent if possible. What about heart failure? This patient has heart failure. So all the admitted patients with the cardiac issues, 17% will have AFib. And if you look at heart failure population, more than half of the heart failure will have AFib at some point of time. And around 1/3 of the AFib patient will have heart failure. And that increases the mortality around like 3 times. And ablation improves survival in these patients. The other challenge is that to really devise which way to go. And, basically for ablation, we have 2 technologies, catheter and cryo. There are some surgical options we have, and there are some newer technologies I can talk about. But the first therapeutic challenge we have is that antiarrhythmics don't work for a long time. You can see one of the trials, the recurrence rate was around 80%. And in some other trials, it may be somewhere between 20 to 40% patient will be in sinus rhythm after 2 years. So antiarrhythmic therapy is not a good option for long term. Let's look at the Cabana trial. It was one of the most sought after trial for AF, where they randomized between ablation and antiarrhythmic therapy. And the premise was the mortality, but this does not pan up most likely because of lots of crossover. But if you look at ablation group with symptomatic AF, the recurrence is much lower. Whereas with the drug group, symptomatic or asymptomatic AF is very low. So overall, after a few years, like 4 to 5 years, only 20-25% people were in sinus rhythm, despite changing multiple drugs. And you can see that ablation reduces the risk of symptomatic AF by 48% when you compare to drug therapy. Now, how we do? So cryo is in the fashion these days, where you can go and occlude all the 4 veins and create a line of block across the veins, because in 90% of the patient, source of AF is in the veins, pulmonary veins in the left atrium. In the catheter ablation, we create a line of scar around the pulmonary veins. This is left atrium, and we block those firing from the veins to the heart. Now, why ablation is better? The recent trial that's called early AF trial, where cryoablation was randomized against antiarrhythmic therapy. And if you can see that in 1 year, around 60% people with ablation were in sinus, and only around 35 to 40% patients were in sinus with medical therapy. And that is for the recurrence of 30 seconds of AF. If you look at symptomatic AF, like people don't feel sometimes 30 seconds of AF, but if they have more, they can feel it. And when they looked at these patients, interviewed them, and look at the EKGs or Holter, the symptomatic atrial arrhythmias, AF or atrial tachycardia, was only around 80, like around 10 to 15% in ablation group. Now, is it safe? There's always a question about that. And now catheters are more like they have the force sense at the tip. So the catheter tissue interface force can be sensed. So we just don't like poke the atrium too much and risk the risk of perforation or complications. And you can see that this also allows us to have a good contact for good ablation results. And around 80% of people are in sinus rhythm after new ablation techniques. This is for paroxysmal AFib at 1 year. We talked about 2 techniques, catheter and cryo. If you look at that, freedom for any arrhythmia is around 60% to 70%. And if any tachyarrhythmia with symptomatic is around 65%. So we can say that 2/3 of the people who undergo catheter or cryo are in sinus rhythm or asymptomatic in as far as AF is concerned after a year. And AF burden really declines a lot. We call about recurrence if there is 30 seconds of AF after 3 months of ablation or 4 months of ablation, you call it a recurrence. But if they have no AF for next 2 years, then the burden is 0. That's what patient wants. So we look at the burden, which is more clinically important. And with ablation, the burden is definitely low as compared to medical therapy. Now, what about long-term? Most of the results are shown in 1 to 2 years follow-up. Few of the long-term follow-up have shown that if patient undergoes more than 1 ablation, at 5 years, around 50% of people at 5 years, around 80% of people are in sinus rhythm. But if you do last ablation, any ablation, there's 50% chance of recurrence. What about 10 years? For paroxysmal AFib, these results are very good if there is a multiple ablation. So 2/3 are there in sinus rhythm. Now, with the new catheters, we have seen that success rate is still around 75 to 85%. What about risk? Now, the risk of tamponade is very low now, like 0.6%. Risk of death is very rare. We give fluids to irrigate the catheters. So the risk of pulmonary edema is there, 1 to 2%. we had seen a lot of vascular complications like AV fistula while taking the groin access, but with the use of ultrasound, we have minimized it to like almost zero. Some people, they have multiple comorbidities and they're hospitalized for a long time. So after 3 years of initial presentation, he was catheter AF was performed. He was continuing on same medications. But in 5 years, 5 years later, he had recurrence, even on dofetilide. He was cardioverted and see how he does, but the arrhythmia recurred in 3 days. And then he had fatigue and again, class 3 heart failure symptoms. So now the question arises, the gentleman had good antiarrhythmic therapy, had a heart failure, which improved after ablation. Now he recurred. And now this is persistent AFib. So now we call it the hearts that left the bar, because the success will drop with single ablation because he's in persistent AFib. If we repeat ablation, like more than one, then we can achieve the same result, but he may have to go to 2 or 3 ablations in the next 5 to 10 years. So if we have to intervene, we would like to intervene in the early phase, in paroxysmal. As you see, the results are so low with one ablation in persistent or long-standing persistent. If you repeat procedures, then you achieve around 60 to 85% success. Now, why this is the success is low? If we look at the mechanisms, this is very complex. And in fact, we don't know much about it. All we know that in initial phase, the foci are in pulmonary veins, but later on in persistent phase, there are lots of fibrosis. There are areas we call it triggers, and there are areas we call it like substrate, where some maybe reentrant area, maybe rotors. So if we are in early phase, that is paroxysmal, then we can just isolate all the 4 pulmonary veins and results are very good. If they are like persistent AFib, then we have to create a line like maze, these ablation lines, to block those macro reentrant circuit. Or we ablate areas where there are some reentrant circuit, we call it rotors. And you can see the example. This is the intracardiac electrograms where you can see single APC in the left atrium initiates rapid AFib. And this is one which we really go and target that, because those areas of scarring or functional blocks, the reentry can happen. And you can see that they can be like, looks like a flutter, or there could be a lot of slow conduction around the localized area in the left atrium. And we use the mapping system. We can map those macro reentry and block the circuits against natural barriers such as mitral annulus, or there's scar there. So there are 3 strategies to ablate persistent AFib. One, just do the ablation around the pulmonary vein, or try to ablate those complex electrograms, or create the lines like maze. As you can see, there are 4 pulmonary veins. This is a line from pulmonary vein to mitral annulus. We can isolate the posterior wall by ablation. But guess what? In the STAR AF, the results were same, whether you just perform ablation around the pulmonary veins, or you do all the complex fragmented electrogram ablation, or you do lines. The issue with this study was that the pulmonary vein isolation arm had very few patients. We also used rotor system where we can put a basket 64-pole basket catheter in the left atrium. And we look at the areas where there was a re-entry. You can see that there's a re-entrant circuit with the software. And we tag those areas and then ablate those, which can terminate tachycardia in many cases. Those rotors can also be found by using an external jacket, multipolar jacket, and we can find the circuits in the left atrium, and that can be ablated as well. But none of these methods have panned out that great by many of the operators, maybe because of individual experience or due diligence. In our place, we have shown that rotor ablation, we published in JACC, that results are around 80 to 85% for recurrence of AFib. So 80 to 85% remains sinus in around a year. If you look at any AT-AF, because after that you can have atrial tachycardia, then 2/3 patients are in sinus. There are some new technologies, just like high power, which we use, short duration. There are some 90 watt power. This is called Q-dot technologies, which is being investigated these days. There are multipolar catheters, the cryo catheters, laser, but none of these have really come in the US as a regular use. Maybe in next year or two, we'll be using Q-dot, which some of the centers have already started, maybe multipolar catheters. And when we do this, as I said, multiple lines can come like loose, and you can have macro reentrant circuit after ablation of persistent AFib. And we deal with that with mapping them and creating lines just like maze. You can see the 4 pulmonary veins, just a regular pulmonary vein isolation. When it recurs, you can do posterior wall isolation in the posterior left atrium. This is one of the patient which we had a circuit here. You can look at that carefully. This is the anterior left atrium, and there was some scarring developed and circuits were going there. What we did is that we ablated around that area, around the scar, and tachycardia terminated and did not recur again. There's another area of reentrant circuit. You can see this is right atrium, superior vena cava, inferior vena cava, tricuspid valve. And this is your tricuspid mitral valve, and you can see a circuit originating from the septum. And we ablated in the septum and terminated tachycardia. This patient is around 6 years past in sinus rhythm after that.
Can I request you for, conclude and summarize?
Okay, sure. So basically, what we do, the gentleman, so how to initiate this AFib program, here we can talk about if somebody has a question, but basically this needs a multi-specialty care needed for AF ablation. And if you have a good team, you can manage this well. In conclusion, is early intervention of AF is safe. It's better results. More than one ablation is needed in 80 to 85% patient. If persistent, you need experienced operators. In heart failure, AF reduces the mortality, and it needs a teamwork, and patient education is an integral part of AF center. Sorry for the long talk. Thank you.
Time, we just the talk was very excellent one, and we wanted to hear.
Thanks. I thought I had half an hour time, so thanks a lot. Though you have any questions?
That's the problem.
Yeah.
We can have 1 or 2 questions if anybody is interested. Do you want? No. You can ask something from Dr. Das. Early intervention in atrial fibrillation. What will learn the message?
I ask one question.
Yes, sir.
I am Dr. Chatterjee.
Yes, sir. Yes.
Can I ask?
Yes, sir. Yes, sir.
Yes, sir.
You can.
Please stop sharing the slide.
Please. I mean, I just want to know what is the minimum time limit? Excuse me.
Yes,
What,
Dr. Chatterjee.
what is the minimum duration of atrial fibrillation in a patient when we will call it as a paroxysmal atrial fibrillation?
Less than 7 days, you know. And if you can,
That means what? Means what is
Like-
the particular day?
like any recurrence for an hour, half an hour to 7 days is paroxysmal. After 7 days, if it is called persistent, if you can cardiovert them.
No, suppose someone gets only atrial fibrillation for 5 seconds or 10 seconds. What will you do for that?
Well, by definition, we call it 30 seconds now for
Yeah.
recurrence. So when we can catch all those in Holter monitors, we really don't do that. We look at their CHATS VAS score and risk for AFib, and that's what we tell them. Just look for any symptoms, but we won't treat that.
Okay. Okay. Thank you.
Thank you. Now we make